All right, well, welcome back, everyone. Today is another special edition of Healthline 3, and joining us today is Dr. James Howell with the Willis Knighton Bossier Surgical Associates. He is a general surgeon, and he's been in practice for quite some time now. Welcome to Healthline 3 and to our family. We're so excited to have you on today.
Well, thank you very much for having me. I'm happy to participate.
All right, Dr. Howell, we got a few minutes to delve into exactly what it is that you do, but let's learn a little bit more once again about your surgical specialty as a general surgeon.
Well, as a general surgeon, it covers a wide range of responsibilities, mostly related to intra-abdominal surgeries. We do a lot of gallbladder surgery, a lot of appendectomies, removing the appendix when it's diseased. We do surgeries for the colon cancer, benign disease of the colon, such as diverticulitis. We also do a lot of surgery that's outside the abdominal cavity, what we commonly refer to as lumps and bumps, things like cysts, benign fatty tumors, and sadly, sometimes we have to do amputations and several other things that don't fall into any of those categories.
All right, and you mostly said that you see a lot of people coming in with gallbladder disease. Is that correct?
That's correct. Dr. Band and I are very lucky to be busy with gallbladder disease here. We each do about 300 gallbladders a year, and that's a pretty fair amount.
All right, let's talk a little bit. Let's go back. I want to learn a little bit more about your training and your practice.
Sure. Well, originally, a little bit about me. I grew up here in northern Louisiana in Natchitoches, born and raised in Natchitoches, Louisiana. I went to college in Monroe. It was called NLU at the time. And then after college, I was fortunate enough to be accepted into medical school. I decided to attend the medical school in LSU in New Orleans, and that was 4 more additional years of study. And then when I finished that, I felt a calling for general surgery, and I applied to some surgery programs and was fortunate enough again to get accepted to the surgery program here at LSU Shreveport. And that was a 6-year program where I pretty much did nothing but learn how to be a surgeon.
All right, so we've got quite a bit of training there that you've had, and you're also a local boy, which is always a great thing. As a general surgeon, do you perform both elective and non-elective procedures?
I do. My practice is probably about 50% elective and 50% urgent/emergent. We cover the emergency room here, Dr. Band and I, 24/7, 365 days a year. And if someone comes into this emergency department and needs surgical treatment, we step up and take care of that problem. So yes, we do both elective and emergent surgeries.
And we kind of talked a little bit about this just a few minutes ago, but regarding the abdominal pain, what are some of the most common underlying causes that you do treat? I know you mentioned gallbladder.
Yes, gallbladder, certainly one of the most common underlying causes. Appendicitis, another very common underlying cause of abdominal pain, if we're strictly speaking about surgical causes of abdominal pain. Those would be the 2 most popular. In addition to that, patients can have hernias of the abdominal wall that can cause abdominal pain. And unfortunately, sometimes intra-abdominal tumors, colon tumors, colon cancer can become so large that they start to cause pain as well. People commonly will have pain from what they call scar tissue after surgery, what we refer to as adhesions. And those are the more popular causes.
This is a big deal, I think, because I remember years ago seeing people who were passing away from issues like colon cancer. Is this something that is very treatable?
Yes, and I think I wish as general surgeons we could take all the credit for that, but the credit actually I think is more deserving to our GI colleagues who are performing colonoscopies and removing the polyps in the colon, the little growths, before they can turn into something bad, such as cancer. And that screening process has really cut down on the amount of colon cancers that we see. We do still see a fair amount of colon cancer that does require surgery, and the treatments have gotten a lot better too. On the other end of that, once we perform our surgical treatment, I think the oncologist, what we commonly refer to as the cancer doctor, their treatments have improved as well. And I think it's made for better outcomes for that disease for sure.
All right, and tell me a little bit about some of the basics about clinical presentation, diagnostic workup, and treatment of gallbladder disease.
Well, the most common presentation for gallbladder disease is going to be abdominal pain, usually in the mid-abdomen or right upper quadrant of the abdomen, just underneath the rib cage. But the gallbladder is a really great imitator. There can be a wide range of symptoms attributed to gallbladder disease. Some patients will just have nausea, most commonly after eating. Some patients will get pain up into their chest and feel like they're having a heart attack. And after their cardiac workup, we come to realize that it's been the gallbladder the entire time. Once we feel like a patient has some gallbladder disease, the most commonly utilized test is an ultrasound, which is a painless test where they place a probe on the abdominal wall and can actually see images of the gallbladder and identify stones in the gallbladder. And that's a very commonly used screening test for gallbladder disease or gallstones. And most of our surgeries result from having stones seen on that test. In addition, something fairly new, probably more than 20 years old, but in general surgery, that's new. They have a test called a HIDA scan, which is a nuclear medicine test that will actually test the function of the gallbladder. If the gallbladder is not squeezing correctly and has a diminished what we call ejection fraction, that is the amount of bile that's being squeezed out of the gallbladder, if that's low, that can be just as bad as having gallstones, and those patients require surgical treatment as well.
All right, Dr. Howell, thanks so much for answering my questions, but we certainly have callers that are calling in right now, and they want to ask you some questions as well, and I believe we have Shay on the line to ask you a question today. How are you doing today, Shay?
I'm good. Hi, Dad.
Hi, darling.
Aw.
I'm calling in from my 7th grade science classroom. We're watching, and my students are very big Grey's Anatomy fans, and they had a question for you.
Okay.
They wanted to know if you see a lot of trauma-related things, or work with a lot of trauma cases, or is it more things that are planned ahead for surgeries and that type of thing?
Okay. Well, we do not see much trauma out here. We're blessed in this region to have a level 1 trauma center. And the majority of major trauma goes to that center. That's the whole different type of setup and system needed to manage that. That's a very difficult burden, and we do not do that out here. We do see some trauma that we're happy to take care of. In my training, I saw a lot of trauma, took care of a lot of unfortunate people in automobile accidents, gunshot wounds, stabbings, falls, and learned how to do all of that there. But that has become a very specialized field at this point.
Now, Dr. Howell, has that helped you, your trauma kind of exposure when it comes to the sutures and kind of closing up wounds? Has that helped you in your practice now?
Oh yes, it's helped me, because even with elective cases and our emergent cases, sometimes you find yourself in a tough situation, and I know from my training that I have the skills and capability of handling those spots and getting out of trouble as needed. And I think it was a good experience. It was a good learning experience, especially as a young surgeon, learning how to operate and take care of what was sometimes catastrophic problems is very valuable.
I feel like I hijacked the conversation. Shay, do you have any other questions for your dad today?
No, we don't. Thank you so much, Dad. My kids are freaking out.
Oh, I love it. They're on television. Their voices are on TV right now.
Amazing. Thank y'all so much. Hi, Dad. Love you.
Oh, thank you, Shay, for
you.
calling
Thank
in.
you.
How precious is that? Well, obviously, you're a family man. You're from this area, so people always love to see that, because they know that you work here, play here, and you're going to give back to this community by doing your very best job and putting your best foot forward. Absolutely.
I've always considered myself a Louisianan, specifically a northern Louisianian, and I'm very happy to be in what I consider home.
Oh, I love it. And it sounds like you have a beautiful family there. Shay sounds so sweet. All right, let's talk.
Thank you.
Let's talk a little bit about the pandemic. How has this impacted general surgery altogether, or has it?
It most certainly has. 2020 was a very difficult year for myself and Dr. Banda. Certainly in trying to to be responsible and keep the community safe, there were a lot of recommendations made regarding surgery, essentially the cancellation of all elective surgery. We were not allowed to do any operations unless we could prove that it was an emergent problem that had to be addressed. And certainly Dr. Band and I will always do what we feel is right for our patients in the community. But there were some severe consequences for those surgeons who continue to do elective cases, possibly even suspension of your license by the state medical board. So it had a really large effect on us, but we had a lot of good support from Willis Knighton, and were able to take care of the emergency surgeries without any difficulty. Just a really difficult and scary time.
Absolutely. We know a lot of people are still trying to understand what's going on now as we're slowly coming out of it, and people are still, very hesitant, especially when it comes to getting that COVID-19 vaccine. So I kind of want to transition away from what it is you do on a daily basis to talking a little bit about the vaccine. Is it safe? Is it something that you have gotten yourself?
Well, first, a disclaimer, I'm not an epidemiologist or an infectious disease doctor, but in my opinion, I feel like it's safe. I was one of the first ones to step up and get the vaccine, which was provided free of cost by Willis Knighton, and I had no issues with it. I have my children have been vaccinated. I encourage my friends and colleagues all to be vaccinated. Most have, and I feel the benefits of that vaccine far outweigh any risk. Absolutely.
Let's talk a little bit about hesitancy in operations. Have you been hesitant at all on treating patients who have had COVID or currently have COVID?
No, not hesitant, just mindful. The first thing I'd like to address is the patients who have had COVID. Some of those patients, although they don't have an active infection, still have some of the after effects, mostly regarding the lungs and difficulty with their respiratory tract. So we do have to take that into consideration. There are some patients who are COVID positive, and some that certainly I have operated on who do have an active COVID infection, but they have a surgical emergency that has to be addressed. I'm not hesitant to help those patients, but there are a lot of protocols that the Willis Knighton system has put in place to keep the patients safe, the patient we're operating on safe, the patients around them safe, and our staff safe. And following those protocols has made it where we can perform these surgeries at a minimal risk to not only other patients, but our hospital personnel.
All right. And have you encountered instances in which patients have actually waited a little bit longer than they should have to seek medical treatment due to fears of COVID?
Yes. And those patients actually, thank goodness, are starting to come back to us now. But, classically, just a couple of weeks ago, I saw a gentleman with quite a large hernia, and he had had it for a while, but he didn't want to come in 2020. He's kind of an elderly gentleman, and he did not want to come in because he was afraid to be around the hospital and possibly contract COVID, the COVID virus. And that's just one example of many things that I've seen. Over time, hernias will get bigger, and his was certainly quite large. So, but the patients are starting to come back. Our practice has really picked up. We're fortunate enough to have a very busy practice here, and the patients are returning.
All right, sounds good to me. And what would you recommend for someone out there who is hesitant, but they do have a surgical need?
I would recommend that they come and have a face-to-face visit with the surgeon. Your surgeon should always be able to explain to you in terms that you understand exactly what the issue is, how the issue needs to be addressed and fixed, what the expected outcome is, and what some of the possible complications or difficulties with the surgery should be. And the patient should feel comfortable with that conversation and agree to the surgery. Certainly, it's not my job to try to make anybody do anything, but I do feel like it is my job to educate the patient and help them make a good informed decision and let them know not only here's what will happen if we do the surgery, but here's what could happen if we do not. And I think every surgeon should be able to communicate with their patients in that manner and allow them to make good choices.
Absolutely. I think good bedside manners make all the difference in someone's health, is them really understanding and knowing what their options are. So I want to kind of backtrack a little bit. We talked a lot, we kind of jumped all over the place, and that was because of me. We talked about appendicitis, gallbladder disease, cancer, colon cancer. Starting off, before you get to that point, when should a patient decide, hey, I need to go see someone like you?
Well, I would say any abnormal abdominal pain that's significant enough to really get your attention. I mean, we do all have little stomach aches and problems from time to time, but I would say recurrent abdominal pain, you shouldn't be having this type of thing happen all the time where you're hurting or nauseous after eating. That's not normal. In addition to that, if you get a severe abdominal pain where you are uncomfortable and cannot get comfortable, most of the time I would urge those patients to be seen at the emergency room here at Willis Knighton Bossier, or we have a quick care here, any of these urgent care facilities to get evaluated, because things can go south rather rapidly if you have a true surgical emergency. And we're also extremely lucky here. We have a good network of primary care physicians, and they do a great job of figuring out what's wrong with a lot of these abdominal pain patients and getting them referred to us when it's a surgical issue. So we have a great support network there.
Have you seen any situations where maybe someone does have extreme abdominal pain, but it goes away in a couple days, and maybe months later it comes back, it's a sharp pain or some other type of pain? In situations like that, do you recommend that the patient should go and see the surgeon even though it kind of comes and goes? Or is it something that should be progressively and consistent? Oh, go ahead. Sorry.
Yes, ma'am. There are some surgical entities, again, back to gallbladder, especially the gallbladder. Sometimes the patients have a severe attack and then won't have any problems for 2 to 3 months or even further down the line, and then get another attack. I would say if you're having severe abdominal pain, regardless of the frequency, I think that needs to be investigated.
All right, so definitely, do they need to go first to their primary care physician, or can they just call you directly? Do they first need to get that recommendation to go to you and be referred?
They can do either. We certainly take patients who call and want to come in and see us, who feel like they have a surgical issue. We're happy to visit and evaluate those patients. We're also welcome to any and all referrals from our colleagues. So either way is fine.
I have a question when it comes to appendicitis. I feel like back in the 70s and the 80s, you saw a lot more people talking about having an appendicitis. I don't hear about it as much now. Why is that?
I'm not sure. I think maybe now because the treatment is so effective and rapid. We do this now with the laparoscope with 3 tiny incisions on the abdomen. And the surgery itself maybe takes 20 minutes, and the patients are home usually in less than 24 hours, and the recovery is very rapid. And I think for that reason, most people probably don't even bring it up, as opposed to back, in the time frame you mentioned when they were doing this procedure with an open incision on the abdomen, spend 3 or 4 days in the hospital. I think it was a much bigger ordeal and more likely to be talked about at that time.
Absolutely. So tell me, in your practice and in the time that you've been doing general surgery, what are some of the big changes that you've seen over the years in terms of the type of treatment that you can provide? You just said it right there with the appendicitis. Things have changed so much.
Things have changed and are changing all the time. That's why I feel it's important that we keep up with what we call the literature, surgical journals that have new treatments and new procedures. One of probably the biggest change I've seen, which is probably going to be the answer for all surgeons in my age range, is the advancement of what we call minimally invasive surgery, which is laparoscopic surgery and robotic surgery, where tiny incisions are made on the abdomen. A camera is inserted into the abdomen, and you can view the abdominal contents on a television monitor and perform these surgeries through tiny incisions. That was really beginning to take off towards the end of my training, and has skyrocketed. And I think that by far has been the biggest advance and change in the treatment of surgical disease.
Dr. Howell, I think it's so important when you come across a surgeon or even a physician who, like you mentioned, reads those surgical journals or medical journals constantly, staying abreast with what the latest is. How big is that in your in your care, in what you do, and you're in trying to prepare yourself and constantly stay up to date with what's going on?
Well, it's important. You want to know what's going on out there. General surgery, I would be honest with you about that. It just changes at a glacial pace because the founding fathers of general surgery, did such a good job with some of these operations. Some of these operations we're doing are 50, 75 years old or even older, and it does change at a slow pace. But it's important to know what's going on. I had my very wise surgical chairman, Dr. John C. McDonald, said, you don't want to be the first person to try something new, but you don't want to be the last. And so I've always tried to practice. I've always tried to kind of fit in the middle, make sure that something that's sort of experimental, let's make sure it's safe and good for the patient first, which takes years. And once we know that it's safe and good for the patient, then I try to assess whether I want to incorporate that into my practice. Is it right for me? Is it right for the people I'm trying to help? And that's how I've always practiced.
I love that. Great philosophy there. All right, let's go back to talking a little bit about this laparoscopic surgery. I'm very interested in understanding how it is that you can do a surgery in 20 minutes.
Well, I can tell you that doing it thousands and thousands of times helps. And also having good personnel. That's the thing about surgery. It's not just a surgeon, it's the help you have. I'm so lucky to have really good help. I have a lady, Miss Jackie Phelps. Hi, Jackie, who's been with me since I started here. And she's my right hand, assists me in the operating room. She knows all the moves of the surgery, and that helps tremendously. I work a lot with the same nurses and what we call scrub techs, people that pass you the instruments during surgery. I work a lot with the same people here for years. And they know all the steps to the surgery, and it's just a very streamlined process. And sometimes takes a little longer, sometimes a little less. It just depends. But with all that good help and having done this so many thousands of times, it's a pretty streamlined process.
All right. And are you seeing a lot more patients coming into your office now?
As opposed to 2020?
Yes.
Yes, ma'am. It has really picked back up. And we're thankful for that. But I like to be busy. I enjoy my job, and it's nice to have the patients returning, because these patients they don't come here. By the time they get to my office, usually they're not here with something that doesn't need to be addressed. And if they need help, that's what I'm here for.
Absolutely. I feel like surgeons during 2020, you guys look like you were going to, fall off the deep end because you're so used to constantly working your brain, and all of a sudden things stopped. And we had one surgeon who was in here telling me that his wife had a very long honey-do list for him.
Yeah, well, it really made me rethink retirement, which I'm still a fair ways away from, I think. But there were some days when I would be done and nothing to do and be at home, and I had done all I could do at home, cleaned all the baseboards, painted, done everything, and there was just sitting around. I was like, oh boy, I don't know if I could ever retire.
All right, so we're not going to see you at the Home Depot anytime soon. That's good.
No.
All right. Well, Dr. Howell, we've got about, I think, 7 more minutes left. Tell me a little bit about something that we don't know about you. Anything that I haven't asked.
Well, I can tell you something that people usually find interesting about me. In about the 3rd year of my residency, we had my daughter, which we talked to earlier, Shay. And then about 3 years or so after that, well, close to 4, I had triplets.
Whoa.
And I had that in my last, we had the triplets in my last year of surgery training. And that was something else. I actually was looking forward to taking call at the hospital so I could get some rest, as opposed to being home taking care of these tiny babies. But they are now 20 and all in college and all doing well.
Oh my goodness, all in college at the same time. I hope we had a really good education financial plan to help them out.
We did, and I'm working really hard to keep all that plan going.
Oh my goodness. All right. So, I love that story. 3 children all at once. Obviously, it was not expected. So 4 babies total there.
Yes, it was almost a basketball team in an instant.
I love it. Absolutely wonderful story. All right, let's talk a little bit back to what it is that you do. We're talking about general surgery. You say that you see a lot of patients with particularly abdominal pain, gallbladder disease. It was something that we touched on just last month, but I think it's so important that we revisit it because a lot of people really don't realize that they might have gallbladder disease.
That's true. And like we discussed a little bit earlier, the most common symptom is going to be pain, usually pain after eating, usually in the upper abdomen. Sometimes that pain is associated with nausea. Sometimes they just have nausea. But if you're having difficulty with meals after eating, you probably need to get that checked out. A lot of patients will say, well, I just have heartburn or reflux. And that's actually a very different entity. And the whole time they've been having gallbladder trouble.
So what do you recommend? Because a lot of times I think people will have pain, but we put it off. We say, no, this is nothing that's too big. And that's where we could run into some serious issues.
That is true. There are a few very unfriendly things that can happen with untreated gallbladder disease. The gallbladder can become infected and get severely infected. And last week I took a gallbladder out that was had some gangrenous changes in it, and that makes you extremely ill and possibly even septic. In addition to that, patients with gallstones, especially small gallstones, these stones can actually get out of the gallbladder and migrate through the biliary tract, clogging things up along the way. And unfortunately, they can also clog up the pancreas, another organ in your upper abdomen, and give you what's called pancreatitis, which can be a severe life-threatening problem. So you don't want an infected gallbladder, you don't want a gangrenous gallbladder, you certainly do not want pancreatitis. And all these things can be prevented by timely treatment.
And I think we have about 4 minutes left. Where can people find you, and are you accepting new patients right now?
I'm sorry, what was the first part of the question?
Where can folks find you? How can they get in touch with you, Dr. Howell?
Yeah, we're located here at Willis Knighton Bossier. My office number is 746-4460. They are welcome to call with any questions, concerns, appointments. I operate exclusively at Willis Knighton Bossier Health Center. Dr. Banda and I have been partners for about 15 to 16 years here in this office, and we're very easy to find.
I love it. And you're also a local guy from Natchitoches with 4 children, all girls?
The one we talked to earlier, Shay, that's a girl who's graduated, thank goodness. And the triplets were 2 identical boys and a little girl.
Oh my goodness, it's like the perfect little matchup there. 2 and 2, I love it.
It's been something.
Well, it's been such a pleasure chatting with you. I think we just got 2 minutes left. Is there anything else that I've left out, anything that we're not mentioning that you think is important to get across today?
Well, I would like to just touch back on what you mentioned earlier about those patients with abdominal pain who are hesitant to seek treatment. There are just so many things in the abdomen that can eventually become catastrophic. And I think it's important, you know your body, and you know when you're not feeling right. And it's important to get these things checked out. It may amount to a bunch of nothing, but it may also amount to something that needs to be addressed to prevent a larger issue. So I would say, please don't be hesitant. Find a surgeon that you can communicate with, that you feel like is explaining things to you adequately. And if you feel like you don't understand something, say so. Any surgeon should be able to break it down so that you understand what's happening. And that way we'll be better able to help and serve you and prevent larger issues.
And Dr. Howell, I really liked how you mentioned, nowadays with all the advancements that we've seen in modern medicine, surgeries are quick, they're easy, they're not what they once were. So those fears really shouldn't be there.
Yeah, that's true. Certainly any surgery, much like life, there's always risk involved. But nowadays the risks are incredibly minimal. Depending on what surgery we're talking about. And like you just mentioned, like the gallbladder surgery, that's going to be 4 tiny incisions on the abdomen done with the laparoscope, as opposed to when I first started training, the big giant incision under the ribs on the right side in the hospital for a week. It's a lot of things these days are treated much easier and better, and much easier on the surgeon, and most certainly much easier on the patient, which
All
is the
right.
important thing.
Dr. James Howell with Willis Knighton Bossier Surgical Associates, thank you so much for joining us today, sir.
Yes, ma'am. My pleasure.
All right, have a blessed day, and thank you everybody for watching.